Welcome to the Severe Sepsis Across the Continuum of Care conference call. My name is Bianca, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Ms. Nadine Stadtmeyer. Ms. Stadtmeyer, you may begin.
Good afternoon, everyone. Thank you for joining us this afternoon to hear Dr. Stephen Simpson discuss the subject of sepsis with us. I know that this is something that is becoming more and more relevant in all of your lives as the sepsis measures go live beginning October 1st. And Dr. Simpson has some intriguing, thought-provoking things to tell us about the subject of sepsis. Dr. Simpson is a professor of medicine and acting director of the Division of Pulmonary and Critical Care Medicine at the University of Kansas. He is also the chair of the Interdisciplinary Critical Care at KU Hospital and medical director of 3 of its ICUs. He's a member of the board of directors of the Sepsis Alliance and of the board of regents of CHEST. He has done research in all areas of severe sepsis, from molecular and cellular mechanisms to translational studies to quality improvement studies. He was the founder in 2005 of the Midwest Critical Care Collaborative and a multidisciplinary and interprofessional collaborative effort to improve the quality of care services throughout the Midwest. In 2007, he initiated the Kansas Sepsis Project, which is a statewide program to improve severe sepsis care and outcomes throughout the state via conducting continuing education both in sepsis and in quality improvement principles and via interprofessional collaboration. He currently heads a sepsis collaborative across the spectrum of care among Kansas hospitals, nursing homes, and emergency medical systems, and is a contributing faculty of the ongoing Surviving Sepsis Campaign Collaborative, leading the effort in the Midwest. He's a participant in the 2016 review and update of the Surviving Sepsis Campaign Guidelines. He was the North American chair of the International Single-Day Point Prevalence Study for Severe Sepsis and Septic Shock in the fall of 2013. During his tenure at the University of New Mexico, he contributed to the discovery of a particular form of sepsis, a hantavirus pulmonary syndrome, and published numerous papers on the clinical description, the hemodynamic description, and the approach to supportive care for patients with syndrome, including extracorporeal hemodynamic and oxygenation support. He received his MD degree from the University of Kansas. He completed residency training in internal medicine at KU and fellowship training in pulmonary diseases at Rush Medical College. He's been a faculty member at Rush Medical College, the University of New Mexico, and the University of Kansas. He is a regular reviewer for the Journals of Critical Care Medicine and CHEST, and reviews on an ad hoc basis for Shock, the Journal of Intensive Care, JAMA, Virology, and Antiviral Therapy. And having him today is a pleasure because he just arrived back from India in the last 24 hours. I'll turn it over to you, Dr. Simpson.
Okay, thanks, Nadine. And after that introduction, everybody, I guess that's all the time we have time for. So, it's a real pleasure to be here, and we have a lot of material to cover, so we are going to go ahead and get started. Nadine is correct. I just spent 36 hours flying back from India, so I have someone here waiting to kick me as I fall asleep while I'm talking. But let's get started. So here is a quote that I find fascinating by Niccolo Machiavelli, obviously not written in a medical treatise because Machiavelli was a political writer, but I have found this fascinating. Because he quotes what the doctors used to say about sepsis in the 1500s, which is this, that physicians say it happens in hectic fever, that in the beginning of the malady it's easy to cure but difficult to detect, but in the course of time, not having been either detected or treated in the beginning, it becomes easy to detect but difficult to cure. And I'm here to tell you that has been the history of severe sepsis. Up until just recently, but I also want you to know it does not have to be the history of severe sepsis because it actually is easier to detect early in its stages than what doctors have always thought, and that's what I hope one of the things that I hope you'll walk away from this program with at the end. What is sepsis? Everybody stop and think. Most of you are clinically oriented. Many have either MD or RN, BSN type degrees. Think you've all heard of sepsis for as long as you can remember. What is it really? A brief definition that will come out with the new, oops, I just got a big blank white space on my slides. I hope that you can read this. A brief definition that will come out with the new International Consensus Conference on Definitions of Sepsis is that we are going to call it life-threatening organ dysfunction due to a dysregulated host response to infection. The key components of this particular definition are this. Infection must be present. An infection that causes organ dysfunction is the key. We'll march through this as we go. I want to give you an interesting case that was a real case, although I've monkeyed with the presentation just here to make it fit the topic of across the continuum of care. So this is a 72-year-old banker who had recently been hospitalized with a hip surgery and was first relegated to spend some time in a nursing home before going to rehab. He had been a working banker before that. I'm sorry, he was admitted for a stroke. Had been a working banker before that, managing people's money, and he was oriented perfectly well during his rehab time there in the nursing facility. The aide noted that he was mildly confused while getting him ready for breakfast, and then the vital signs were taken, and you see the vital signs across the bottom here. Blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. And I'm sorry, I'm pointing with my pointer, and I know that you can't see my pointer, so I'll stop doing that. What we know about this man is he has a previous history of having had a ureteral stent placed for his stricture and stones in his left ureter, that he has a history of coronary artery disease, hypertension, and stroke, and he has some residual left leg weakness. He takes medications for blood pressure and cholesterol and for prostatic hypertrophy. So based on the data that you see here, I have a question for you. So what should the nursing home do right now? They should put in an IV and bolus him with lactated ringers. They should give him some oxygen. They should give him point of care lactate level, or they should give him some IV or PO levofloxacin, put in the IV, give him LR, transfer him to a hospital for ICU admission. In point of fact, none of those answers are really wrong, but the absolute key point here is we want nursing homes to recognize what they're looking at, and we will come back to this guy later and look at his case. But we want nursing homes to be able to recognize this guy and initiate the transfer to a facility where he can get care. This gentleman has severe sepsis. So EMS arrives, and what should they do when they arrive? They could do blood cultures. They could apply oxygen. They could measure a point of care lactate level, or they themselves could give IV or PO levofloxacin, a 2-liter bolus of LR, and transport to the hospital for ICU admission. And in case you didn't pick up on it, last time, any of these could be good things to do, and we have EMS units actually gearing up to do point-of-care lactates. Obviously, they can give oxygen. We have EMS units who have taken blood cultures, but the key component of this man's therapy right here is we need EMS to recognize that the patient needs transferred urgently to the hospital. So the patient arrives in the emergency department. What should be done? Blood cultures, oxygen, point of care lactate. Again, levofloxacin, bolus of LR, and ICU admission. And in case you didn't get the picture, the most correct answer is D, but absolutely every single one of those things should be done at the hospital when the patient presents. All of the information was on the initial slide. Many people look at the initial slide and don't really recognize that these things point to ICU admission, not just hospital admission. So we're going to dissect that as we go. Some additional data that was obtained at the hospital showed that his white count was high with 33% bands, platelet count was low, his fibrinogen was low, his D-dimer is increased, he has evidence of acute kidney injury, and he has an increased serum lactate, and we will come back to these measures later. So severe sepsis is actually the number one cause of death in the world, and if you stop and think about it, I just came back from India. There are plenty of places in India where people don't have access to antibiotics in the small towns and villages. There are plenty of places in Africa, plenty of places in Southeast Asia. In fact, outside of the U.S., Western Europe, Australia, and the Pacific Rim, and some central metropolitan areas in India, many people in the world do not have a way to treat their infections. And if you stop and think about it, you will recognize that infection is probably mankind's oldest enemy, and yet we still can't combat it. So actually sepsis is the leading cause of death worldwide. In the United States, if you go into an ICU for any reason, the thing most likely to kill you is sepsis. As a matter of fact, I'll take a step further because now I have worked with enough hospitals to know that sepsis is the number one leading cause of hospital mortality across the board. This slide listed as 11th leading cause of death overall. We now think that it's substantially higher than that. There's 750,000 cases I'm showing per year were data from 1995, and I'm going to show you info that demonstrates that we actually have a lot more cases than that now, and a lot more than 500 people a day are dying in the United States from severe sepsis. In our own state of Kansas, I think I actually took the data out, but in our own state of Kansas, where I live and work, we believe that there are, in fact, we know that there are over 15,000 cases, approaching 20,000 cases a year in a population of 3.2 million in our state. We think that 6 to 10, perhaps as many as 15 people a day are dying from severe sepsis. Mortality from severe sepsis is substantial, and you can hone in on the graph that's on the right-hand side here, and what we see is number of deaths. This, again, is data from 1995, but nothing has really changed. You see that although the incidence of acute myocardial infarction is substantially higher, the number of deaths from sepsis was just as many as acute myocardial infarction in that year, and this is held true. As a matter of fact, this is probably an underestimate of the number of deaths from severe sepsis, also because of things like this, that when we look at vital statistics, if a person dies of breast cancer, colon cancer, melanoma, myeloma, you name it, any sort of cancer, the cause of death is listed as cancer, when in point of fact, the cause of death in 50% of cancer patients is severe sepsis, and oftentimes the vital statistics don't record that. Sepsis doesn't just kill you in the hospital. Sepsis kills you after you've had an episode and when you leave the hospital. Just to be on this graph right here, you had to have escaped from the hospital alive after an episode of severe sepsis. So at the XY junction here is time of hospital discharge. There are numerous studies, over 20 studies listed here on the right. The symbols on this graph represent the size of the study and its contribution to the literature. The key important finding is that severe sepsis sets you up for all-cause mortality as much as 50% over the coming 2 years. The thought process is that this results from the system-wide, body-wide inflammation that's engendered by sepsis that sets you up for things like acute myocardial infarction, because we know that at acute myocardial infarction also is initiated by inflammation in atherosclerotic plaques that engenders the blood clot that occludes the artery. And so this inflammation that one experiences during an episode of severe sepsis has long-lasting effects. Your incidence of acute MI is higher if you've had an episode of sepsis. Your incidence of stroke is higher if you've had an episode of sepsis. And again, all-cause mortality is increased. In addition to that, I'm not going to spend a lot of time going through this slide, but I think you will all have the slides available to you if I'm not mistaken. The key point here, this is from a study called the Health and Retirement Study, and you'll see the 4 bars on the left are people who have taken cognitive function surveys in 4 years, then 2 years before their episode of sepsis, and then what has happened in the 2 years, and then 4 years after an episode of sepsis. And you see that the sepsis leaves us with a prevalence rate for moderate to severe cognitive dysfunction of over 15%. It has substantial impact on cognitive function for years down the road. To go along with the cognitive dysfunction, again, I don't have a pointer, so it's difficult to lead you through this slide. But the key thing on this slide, this looks at numbers of limitations to activities of daily living before and up to 6 years after an episode of sepsis, demonstrating that even people with 0 impairments before sepsis are now in the mild to moderate impairment range for activities of daily living. People who were in the mild to moderate range are now up where the people with severe limitations were before. Severe sepsis has demonstrable bad effects on chronic health in terms of cognitive dysfunction and activities of daily living for years after the episode. Now, I will say we believe that the same things that save lives with sepsis, early and aggressive treatment, probably can alter this course, but it just hasn't been studied yet. The best hope we have at present is that adequate, appropriate, aggressive early treatment of severe sepsis can reduce this incidence in cognitive impairment and impairment of ADLs. This graph is important to the future here. This is published in 2001. Again, the same 1995 data that I told you about informs this graph. On the right-hand y-axis, we have incidence rate for severe sepsis during that year expressed as incidence per 1,000 population. On the left-hand y-axis, we have total number of cases. On the x-axis, we have age groups in 4-year chunks from less than 1 to greater than or equal to 85. There are 2 or 3 key points to note here. Number 1 is that the incidence of sepsis slowly rises with age up until approximately age 65 to 69, at which point it takes off asymptotically or exponentially and more than triples between the ages of 65 and 80. So the older we get, the more likely we are to develop an episode of severe sepsis. Second thing to notice, if you look at the little squared boxes, you see that between the ages of about 35 and 50 to 55 on this graph, there is a huge bump in the number of cases of severe sepsis, but that bump doesn't translate to the incidence line. What that means, the only way you can have more cases without altering the incidence rate is if there are simply a lot more people in the population. This data, as I said, was generated in 1995. If you think about it, who was between age 35 and 55 in 1995, it's probably a number of you who are listening. It certainly is me, and it's the generation we call the baby boom or post-war generation. Now, 1995 was 20 years ago. What age group are those people in now? Those people are in the age range of 50 to almost 70, probably 47 to 67 thereabouts. In 2011, the leading edge of this population of people began turning 65 at the rate of 10,000 patients per day, or 10,000 people per day, and that will go on for 19 years. The total number of people that will be injected into the elderly population in that period of time is 39 million. So already what's happening is the baby boomers are beginning to reach the age where the incidence rate of sepsis goes up exponentially, and when we put that many more people into the population, the incidence of sepsis is likely to explode over the coming 20 years. I tell young physicians and medical students that sepsis is likely to dominate the landscape of their career in medicine because of when they are beginning. Even before the baby boomers, the incidence rate of sepsis was climbing at a steady rate from 1979 through 2001. This is data generated by Greg Martin, who, by the way, is a Wichita boy, but works at Emory University in Atlanta, and this was done in conjunction with the CDC. Over this 20-year period, the incidence rate of sepsis they found was increasing at an annual increase on average of 8.7%. The data was repeated a few years later because we got our definitions of sepsis that we're going to talk about shortly in 1992. So Victor Dombrowski looked from 93 to 2003 and found similar numbers that the incidence rate of sepsis was rising by 8.4% per year. Now, if you stop and think about that, those of us with retirement accounts, and I hope that's all of us, would appreciate getting 8.5% per year, because what that means is that our money at a compounding growth rate of 8.5% will double in 8.5 years. And that, of course, is exactly what we want it to do. The number of cases of sepsis in the population every year doubles about every 8.5 years, so that if we were to have 750,000 cases in 1995, we should now be sitting at between 2 and 3 million cases in the U.S., and that is exactly what the most recent CDC-related data demonstrate. So, now that we've talked some about the importance and the likelihood of developing sepsis, we need to talk about what sepsis is. The key starting point is this: sepsis is not equal to hypotension. So if I ask you at first to think about what you think sepsis is, and if hypotension came to mind, you need to know that hypotension is a potential feature of sepsis, but you can have fluid, severe sepsis without having hypotension, and you need to know that. Secondly, sepsis is not equal to bacteremia. Bacteremia can be an infection that causes severe sepsis, but bacteremia is not present in every case. In fact, it's only present in about 25 to 30% of cases, and so you don't have to have bacteria in your bloodstream. What is sepsis then? Well, let's take a look here. These are the ACCP, SCCM consensus definitions agreed upon in 1991 and published in CHEST in 1992. The first key thing to remember is it isn't sepsis unless there's infection. One has to have a good reason to believe that the patient is infected. Now, this does not mean culture positive infection. This means good reason to believe it. For example, I am a pulmonologist. If a patient comes to my office and complains of fevers and chills, feeling poorly, having pleuritic chest pain, and coughing up purulent or rust-colored sputum, and I put my stethoscope on their chest and I hear consolidation, that patient has pneumonia in my books, and I don't even need a chest x-ray to determine that, much less a culture. That's what we're talking about, a clinical syndrome that suggests an infection. Once I've looked at a patient and determined that, I am looking for something called the Systemic Inflammatory Response Syndrome, or SIRS. SIRS can result from a variety of different injuries or illnesses. In fact, it can result from certain normal behaviors. We'll talk about that on the next slide. But we say that if they're greater than or equal to 2 SIRS criteria, then SIRS is present. Again, we'll show you those criteria on the next slide. Sepsis is when we have infection plus at least 2 SIRS criteria, and this is associated with a mortality risk of 5 to 9% historically. This is not the horrible sepsis with a mortality of 30 to 50% that we are mostly concerned about, but it is important. As I often say, if I thought I had a chance of 1 in 20 or 1 in 10 of dying in my car on the way home, I would hitchhike instead. So it's nothing to sneeze at, but where sepsis gets really bad is in the next phase, severe sepsis, where we add in organ dysfunction. We're talking about organ that's dysfunctional but is not the infected organ in general. At this stage, our mortality risk is 30 to 50%. The next phase that we look for is called septic shock. Septic shock is when we have sepsis plus hypotension that will not respond to intravenous volume administration or fluid boluses or fluid resuscitation, as I say on this slide. This historically has been associated with a mortality risk of 60 to 80%, and I think I have the slide in here to show you the data on why. This is SIRS. Interestingly, part of a little graphic didn't show up on the right-hand side, but that's okay. Some of my symbols have been converted into funny-looking little symbols, so we'll have to walk through this. SIRS is nonspecific. It may result from multiple different insults. It is when you have greater than or equal to 2 of the following. We look at 4 things: temperature, heart rate, respiratory rate, and white blood cell count. If our temperature is either higher than 38 degrees Celsius or less than 36 degrees Celsius, to translate that means greater than 100.3 Fahrenheit or less than 96.8 Fahrenheit, then we say that meets criteria as a SIRS criterion. A heart rate greater than 90, a respiratory rate greater than 20, a white blood cell count that's more than 12 or less than, not whatever this little symbol is here, less than 4,000, or that has more than 10% bands or other immature neutrophils. Any 2 of these qualifies you as having SIRS, and it has importance. Takes you from an infection that has no mortality to an infection that is 5 to 9% fatal, just in and of itself. Then we look for organ dysfunction. Which organs can dysfunction? We'll just start from top to bottom. Obviously, central nervous system is best picked up as altered consciousness. However, it is important that we do not discount confusion. One of my favorite questions for a patient I will pose to you right now: what is your home address? How long did it take you to think of that? I often get people in the emergency room or the ICU who go, Kansas City. And I go, that, my friends, is central nervous system dysfunction, because that man most assuredly knows his home address. Cardiovascular. I'm getting some strange things happening here with the slides. I hope you may have physical copy or something. Hypotension. Hypotension that occurs at any time that is due to an infection is an abnormal organ dysfunction. I often get called by ER docs, and they say, well, he was hypotensive, but I think he was just dry because he responded to volume administration. No one gets hypotensive just from being dry in the United States of America. Cholera can make you dry enough to have hypotension. GI bleeding can make you intravascularly depleted enough to have hypotension. Very, very, very rarely a severe diarrhea, maybe a C. diff diarrhea can do this. Otherwise, nothing happens to us in the United States that makes us dry enough to get hypotension. Hypotension is defined, I'm not seeing it on this slide, perhaps you are not either, as a systolic blood pressure of less than 90 or a mean arterial blood pressure of less than 70. In the lungs, we are, of course, looking for hypoxemia. This would be evident as either a Remer PO2 less than 70, an O2 saturation of less than 90%, or a PaO2 to FiO2 ratio of less than 300. Any of these things qualifies as organ dysfunction. We usually, however, discount hypoxemia in patients with pneumonia. Pneumonia at its heart is pus in the lungs, pus in the alveolar space, and there is no way that alveoli can do their job when they have pus in them. And so we do not say that the hypoxemia is due to systemic inflammation in that case. We say that it's due to the pus in the lungs. And so we look for another organ to dysfunction. With pneumonia, I'm getting another blank white space here. I don't know if that's what you're getting as well. If pneumonia causes oliguria or anuria or a bump in creatinine, then we say that that is an organ dysfunction that qualifies. And that's what we look for with regards to the kidneys. That 0.5 milligrams per deciliter bump in creatinine doesn't sound like much to the average person, but we know that women often have a baseline creatinine of 0.5, so a bump of 0.5 would mean to the average woman that she had lost half of her kidney function due to inflammation. T-bilirubin, I'm sorry, this is an older slide that I forgot to update for you. We currently use a total bilirubin that's greater than 2 as our criterion for diagnosing hepatic dysfunction. Thrombostasis mechanisms, again, I'm getting this little white box. I hope you guys are getting a better look at this. Platelet count less than 100,000, an INR that's elevated, a PTT that's elevated, or a D-dimer that is elevated. All are indicative of hemostasis dysfunction and do count as an organ dysfunction for sepsis. And then last but not least, lactic acidosis is a key finding in severe sepsis caused by organ underperfusion, caused by microvascular abnormalities in sepsis. We call each and every one of these an organ that can dysfunction. Historically speaking, each organ that dysfunctions is associated with a risk of mortality of 15 to 20%. Each organ associated with a mortality of 15 to 20%. One of the key problems that you will encounter in your hospital, nursing home, EMS unit, wherever you are with severe sepsis is that it takes thinking through these three things. Is there infection? Is there SIRS? Is there organ dysfunction? It takes lining them up in series and having a yes to at least the infection and organ dysfunction components in order to make a diagnosis of severe sepsis. Severe sepsis, unlike acute myocardial infarction or pulmonary embolism, let's say acute myocardial infarction, does not have a simple yes or no answer. When you come to the emergency room and complain of chest pain, they put you in a bed, give you oxygen, measure a troponin, do an EKG. They do all those things within the first 5 minutes. Why do they do those? Because it's a simple yes or no answer. If there's ST elevation, there's myocardial injury. If there's troponin elevation, there's myocardial injury. Either of those wins you a trip to the cath lab. And we as human beings like to think in yeses or nos, which is why it's a good thing to break down this sepsis diagnosis into is there infection, is there SIRS, is there organ dysfunction. These are yes or no questions that can be answered very quickly at the bedside, but it still is a problem that you have to string together 3 separate questions and it impairs the diagnosis. So I think the key thing that keeps us is our biggest diagnostic challenge is there is no single test or marker that we can send this marker and say, yes, sepsis is present, no, it isn't. It takes some thought process that people don't like to do. Quick question, just to see if you've been listening. Diagnostic criteria for severe sepsis include positive blood cultures and hypotension, positive blood cultures and tissue hypoxia, positive blood cultures, SIRS and lactate, or suspected infection, SIRS and organ dysfunction. And of course, all of you have been listening, so you get that the answer is this: suspected infection, SIRS, and organ dysfunction. In truth, A, B, and C all represent cases of severe sepsis, but they are specific cases, not the broad definition that we need. Infection, SIRS, organ dysfunction. I left in this picture of Roger Bone that I won't dwell on too much. I left it for three reasons. Number one, Roger Bone is the one who developed these sepsis criteria. The list on the right-hand side is all the different ways back in the 1970s that people were diagnosing severe sepsis. He recognized that, actually they were diagnosing sepsis. He recognized that many people had sepsis but never had a positive blood culture, and also that waiting for a positive blood culture certainly put us behind the eight ball in treatment. He developed these criteria, and he had enough clout in the pulmonary and critical care communities that he ultimately got everyone to understand how important they were and to accept them and begin to use them. Number two, I show Roger because he trained me, and so without that, I'd be on a conference call talking about something else besides sepsis. But in truth, I went to train with him because of sepsis. Number three, I always like to point this out to both Kansans and non-Kansans. When Roger Bone developed these, he was about a 35-year-old man, and he worked in an office down the hall from where I sit right now. These criteria were developed at the University of Kansas, and so I always like telling people about that. The role of biomarkers in diagnosing severe sepsis. There is none. Yet. The one that you will be bugged about is procalcitonin. The salespeople for procalcitonin are continually attempting to get people to send it. It is not for diagnosis. Procalcitonin will hold up the treatment of sepsis, which as we're about to show, needs to be rapid. So we do not wait for procalcitonin to make a diagnosis of severe sepsis. It is okay to send it in your initial lab work. If it comes back not being elevated, then it does get you to look for other things, but the fluids and antibiotics that we treat with should not be delayed. Let's come back and look at this man again. Usually I do this with an interactive audience, and I can't do it. Obviously, I have no interaction with you just yet, but so this man has clear signs and symptoms of a pyelonephritis as his infection. And that's fairly easy to diagnose. Secondly, does he have SIRS present? And the answer to that is yes. He has tachycardia, he has tachypnea, and he has fever. So he has 3 out of 4 SIRS criteria present right here in this little scenario. Does he have organ dysfunction? Yes, he does. He has mild confusion that he did not previously have. He has an O2 saturation of 87% on room air, which he should not have from a pyelonephritis. And I will tell you that he had normal saturations previously, so he's hypoxemic. And number 3, that takes a little bit of calculating. His blood pressure of 105/43 gives him a mean arterial pressure of 63. So he is hypotensive. He has 3 organs dysfunctional just on this little bit of slide. I can tell you what would happen to him in the average hospital in America is probably admission to the hospital, some saline running at 100 or 150 an hour, some antibiotics in no particular hurry, and he'd be admitted to a hospital ward. That is exactly the wrong thing to do with this man. He needs to go to an intensive care unit. His calculated historical risk of mortality is 45 to 60%. He needs to be placed in an intensive care unit. To go on and look at the remainder of his labs, there's your 4th SIRS criteria in the white count. His platelet count and fibrinogen and D-dimer all indicate DIC is present. There's another organ dysfunction. He has acute kidney injury, and he has an increased lactate. So in total, he has 6 dysfunctional organs and a calculated risk of mortality of 90% historically. That's why this guy goes to the ICU. Now, all of this would be for naught if we did not have a good, useful approach to severe sepsis, and we do have that in the form of guidelines from the Surviving Sepsis campaign, initially promulgated in 2004, revised in 2008, revised in 2012, revised again, being revised right now in 2016, as any good guideline should be. There is new evidence, and guidelines should be updated to include the evidence. The only purpose of this slide is to show you that it was an organized approach to the entire body of literature on sepsis and severe sepsis, with graded levels of quality and graded levels of recommendation, as all good guidelines should be. What are the things we know from this literature review? That sepsis is time sensitive. Actually, that's a pretty weakly way to say it. Sepsis is an emergency, just as is acute myocardial infarction, where we know that the faster you get your vessel open, the more myocardium you save, the less heart failure results, the fewer deaths result. Stroke, where time is brain. The sooner you get your TPA with a thrombotic stroke, the less brain function you lose and the less long-term disability you have and the more likely you are to survive. Trauma, we've known about the golden hour for many years, and now we need to include severe sepsis because we know that faster treatment improves survival. Severe sepsis should be treated not as a head-scratcher, but as an absolute emergency. Bundles of care, I think you are the wrong audience to talk to and try to teach about bundles of care. I'm sure that every one of you understands the advantages to using a bundle, so I'm just going to go on and tell you. The Surviving Sepsis Campaign recommends the following bundles of care, which were picked up by CMS and placed into the core measure. We start with measuring a serum lactate level. Of course, that can't save a life. But we measure serum lactate because we need the answer to whether it's high or not for step number 4 below. We obtain blood cultures, if at all possible, prior to the administration of antibiotics, but we administer broad-spectrum antibiotics. This means a carbapenem or a third-generation penicillin, or possibly a third-generation cephalosporin, to cover as many bacteria as conceivably possible. In certain settings, we also need an antifungal agent. These should all be given according to the bundle at least within 3 hours. The bundle recommends that these are given within 1 hour. And we know that the faster one receives antibiotics, the more likely one is to survive. If hypotension is present, or if the lactate comes back greater than 4, then the bundle includes the administration and completed administration, by the way, of 30 mLs per kilogram of a crystalloid IV fluid within the first 3 hours. There is a 6-hour bundle that also applies. To be completed within 6 hours, we need to apply vasopressors for hypotension that didn't respond to that 30 ml per kilo bolus. If there is persistent hypotension despite volume resuscitation, which means septic shock, or if the initial lactate was greater than 4, we need to insert central venous catheters for measurement of CVP and for monitoring of central venous O2 saturation. We hope to, with our treatments, normalize central venous O2 saturation within 6 hours, normal being greater than 70%. We hope to normalize the lactate within 6 hours. If you just looked at all that and went, that seems pretty darned easy, you're exactly correct. It is not by any stretch of the imagination rocket science. It's something fairly simple to do. We just need to consistently do it. Just to let you guess, in the early resuscitation of the severe sepsis patient, the most important feature is what? In most people's estimation, it is antibiotics as fast as they can get in, and do not forget, none of these SIRS and organ dysfunction criteria had meaning. They're all caused by the infection. The source needs to be dealt with, and needs to be dealt with as fast as it possibly can be. Yes, I think I did leave this slide in. This is from a friend of mine on Kumar from Winnipeg. He recruited 13 other ICUs besides his across North America to determine whether the timing of antibiotics in relation to the onset of septic shock makes a difference. He shows survival fraction on the y-axis and time to antibiotics on the x-axis. survival historically for septic shock has been 20 to 40%. What Anand and his colleagues found is that if one receives antibiotics within the first half an hour after the onset of septic shock, the survival is 83%. It goes down by 7.4% per hour for every hour of delay in antibiotics. So in septic shock, 3 hours is actually a substantial delay, and we should not tolerate it. If you get to 5 to 6 hours, the survival has now gone below 50%. In these ICUs, think about it, all interested in septic shock, enough to do a research study about it, or wanting to treat sepsis appropriately, the median time to receive antibiotics was 6 hours. No wonder the mortality rate from septic shock has historically been so high. We know a lot of things about sepsis, but we don't necessarily do them. What we know is that there are nearly 20 studies in the literature demonstrating that if you follow the approach that we have just outlined, you reduce the mortality of severe sepsis substantially. This summarizes what we have to do with the CMS core measures. And really, I don't want to take the time right now to walk us completely through this, but you can see on the left-hand side within 3 hours of presentation, this exactly follows the Surviving Sepsis Bundle guideline. No questions about that. In the top part of the box on the right-hand side, we also follow Surviving Sepsis guidelines. The bottom two boxes allow for, instead of CVP, allow for different mechanisms for evaluating the adequacy of fluid administration. That include, as you're probably all aware, a complete cardiovascular physical exam with all of these components documented, or 2 out of the 4 of the following things: a CVP, a bedside cardiovascular ultrasound, central venous O2 saturation, and stroke volume measurement in response to passive leg raise or fluid challenge. I'm certain that you all are getting well versed in these. I want you to know something that we have done. Gosh, I'm not talking quite fast enough, and I apologize. I want to give you the chance for some questions. In Kansas, one hospital in the state is required to participate in the DSRIP, or Delivery System Reform Incentive Payment Program. What this basically means is that payments that were previously made to the University of Kansas Hospital simply for caring for indigent patients are now dependent on University of Kansas Hospital, demonstrating that we have some effectiveness throughout our treatment region. We set up the Stop Sepsis campaign, which stands for Standard Techniques, Operations, and Procedures for Sepsis, and we are aiming to do something that is like this. Actually, first let me say that the Stop Sepsis campaign is a cooperative approach between the University of Kansas Hospital, the Kansas Sepsis Project, KU Medical Center's Continuing Education Department, and the Central Plains Geriatric Education Center. What we did is the Kansas Sepsis Project has been aimed at hospitals all over the state for a number of years. Our aim now with the Stop Sepsis program is to clue in all nursing facilities in the state, as well as all EMS providers in the state, so that the continuum of everywhere that a patient might be receiving care is now trained in recognizing sepsis and aggressively pursuing treatment. I'm going to skip right past this slide. I just want you to see in this slide here, these are the 4 places in Kansas that have a hospital with more than 200 beds. These remainder are below 200, most of them down in the 100-bed range. Everywhere else in the state of Kansas, an additional This is an additional about 105 hospitals are either critical access hospitals or are of the size that they could be critical access hospitals, but simply are not a part of that program. This is the Rural Health Network for our state, the state of Kansas, and this shows the 83 critical access hospitals in the state and who the supporting hospitals are for them. This is a population density map. The lightest color on this map represents what is considered frontier, which is fun given that we live in Kansas where Buffalo Bill used to roam, etc. But frontier, very low population density. If you look at the next map, you will see that this is just the opposite. The doctor density exactly is the opposite goes along with the population density. So that all of these light blue areas are critically underserved areas in the state of Kansas as far as having physicians available. Not just Kansas. This yellow portion here demonstrates a huge swath of the United States where the population density is less than 86 per square mile. This map reverses that and shows you the urban areas of the United States. All the nicely yellow or tan area in this map is non-urban areas. This is where trauma centers are located or where you are within 20 miles of a trauma center in the United States, and you can see it exactly mimics the rest of the maps. This last one from the Dartmouth study here shows that Medicare reimbursements per enrollee versus the percentage of patients who receive recommended care for a condition. On the left-hand map, the light color means the lighter the color, the less the Medicare reimbursement per enrollee. And on the right-hand map, the darker the color, the less likely a patient is to receive guideline-recommended care for any given condition. So you see that amount of reimbursements correlates nicely with nicely, perhaps isn't the right word, correlates with lower quality of care, we might say. This slide simply is to show that we have reduced our own sepsis mortality at the University of Kansas Hospital from 49.1% in fiscal year 05 until now in fiscal year 2014 to 9%. Septic shock mortality has gone from 50% down to 20% in that period of time. This demonstrates that this is not an overnight fix for severe sepsis, but it takes steady, continuous improvement. Having done that at the University of Kansas Hospital, we hope to help patients in EMS systems, nursing homes, and hospitals all over the state to early recognize and rapidly, aggressively treat severe sepsis. And that's what our DISREP program is doing with a series of intensive workshops throughout the state. We have online educational tools as well. We want people to recognize. We want people to give early aggressive treatment. We want to train people also in quality improvement techniques and collecting data, for which we provide an online data collecting tool that's fairly simple to use. And we also provide continual support from expert faculty, which is me and other people on the faculty. So, in summary, severe sepsis is hugely common. There is evidence to support several treatment modalities. Those modalities have now been incorporated into a CMS measure. Early recognition is crucial. Rapid aggressive treatment is necessary, and all of us can do this. I firmly believe that, and that's what I had to say. Thank you very much, and we can try and have some questions now.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Standing by for questions. And our first question comes from Cheryl Woods from Barrett Hospital. Cheryl, go ahead.
Yes, hi. I just had a question. Does having a pre-existing heart condition or liver cirrhosis have an impact on a septic shock outcome, in your opinion?
Yes, it does have an impact on the outcomes. It does worsen outcomes. We know that across the board. You didn't ask the question I thought you were going to ask, which is these people seem volume overloaded. Should they really get 30 mLs per kilogram? And the answer is yes. They should. If someone else asks that question, we'll go into more detail. But yes, absolutely. Previous chronic underlying conditions are one of the biggest contributors to overall outcomes from severe sepsis episodes.
Okay, thank you very much.
Mm-hmm.
Once again, if you have a question, please press star then 1 on your touch-tone phone.
Bianca, we have one from the chat. Someone is asking, most clinicians wait to get blood cultures before administration of antibiotics. It sounds like that is no longer best practice.
Actually, no, it's no longer best practice to wait. It is best practice to obtain blood cultures, but the blood culture should be obtained almost instantly, and the antibiotics should not be delayed for drawing of blood cultures. If you're delaying antibiotics because of drawing blood cultures, then your process for drawing blood cultures should be a focus for improvement.
And our next question comes from Pam Kavaz from Newton Medical Center. Pam, go ahead.
Hi, this is Karen. I have a question about one of our struggles with placing the patient appropriately in the critical care unit. Do you use any predictive scoring systems like Apache, SOFA scores, or a new study just came out called the True Score to help physicians decide and to validate placement in the critical care unit?
Yeah, actually, Karen, we are not using a specific score, and I think people tend to make mistakes when they try and hang their hat on a score, such as SOFA, Apache 2, or even True. The problem with using a score like that is that the scores are validated on large groups of people, and what happens to a large group of people and the predictive validity for an individual patient are two different things. We tend at our hospital to be pretty liberal with our admission to the ICU. If a patient has any evidence of hypotension, if a patient has more than one organ dysfunction, if a patient has mental status changes, they will be admitted to the intensive care unit. Even if they turn around in 6 hours and are sent to the floor, it is a better thing to do for the patient's safety. Are you running into problems where physicians are being criticized for putting people in the intensive care unit?
No, actually it's quite the opposite. Patients should be placed in the critical care unit more often than they are.
Okay, I agree. Well, you just heard 2 or 3 things that will get us to put a patient in the ICU, any evidence of hypotension, any mental status change, actually any hypoxemia resulting from the sepsis, and more than one organ dysfunction. Any of those things will buy an ICU admission from us.
Okay, very good. After some other questions, I do have one other question for you, but I don't have to go right away.
Okay.
Okay.
And by the way, I don't know when we get kicked off of here, but I have some time to continue and answer questions.
Sure. Our next question comes from Charity Lindholm from Cook County Medical. Charity, your line is open.
Hi. What would be your best way to, what questions would be the best for the residents that have dementia already? How would you determine if they have organ dysfunction, if they're already confused?
Yeah, those subtle approaches, or those approaches to subtle mental status changes, are just much tougher in the already demented patient, and so I don't think there actually are questions that you can ask. What I would say, though, is this, that when patients live in a nursing home and people there know them, if the patients are behaving out of line according to what's usual for them, that's what I would consider the clue.
Okay, thank you.
Mm-hmm.
And our next question is from Sarah Haynes from Lawrence Memorial. Sarah, your line is open.
Hi, thank you. Yes, we were wondering, is there any consideration taken when calculating the fluid volume for morbidly obese patients?
Actually, there is not. I did this calculation, and I apologize, I don't have it right off the top of my list. It's not quite fair to say that there is none. If you know the lean body mass of the patient, you can count on at least 50% of the lipid or adipose body mass of the patient should be used. And I'm sorry, I just don't have the numbers off the top of my head, but there essentially is not much of a difference. Adipose tissue is well vascularized, and anywhere that you are vascularized, you need to fill those vessels just like everywhere else. So there really isn't much of an adjustment to make with an obese patient.
Thank you.
You're welcome. You guys also have, by the way, you have in front of you my email address, and if you pop me an email, I will look for that calculation for you and try and get it to you.
And our next question comes from Anuradha Thirumalli from Valley Hospital. Go ahead.
Hi, Doc. I have one question is, I thought you said, when you see hypotension, administer fluids. So, like when we, see a patient, if there is no hypotension, then we don't have to start IV fluid resuscitation?
Yeah, that's a good question, because there is sort of this gray area in the surviving sepsis guidelines. All I can tell you is my practice as a sepsis expert is that if I see organ dysfunction, I give fluid boluses, because that organ dysfunction is resulting from tissue hypoperfusion due to sepsis, and the only way to fix that is with volume administration. So, yeah, it's sort of a gap that the guidelines have left in there. Everyone I know on the Surviving Sepsis Campaign Committee will give fluids for severe sepsis, even without hypotension.
Okay. So, like another question that I had is, inpatient sepsis, when a patient is already admitted and they're in the hospital, how do we, the time is really short. So how do we, capture something within the time frame? We do use a computer system, but I'm not sure, if it's catching on time.
Right. The only way to do this, and this is what our Surviving Sepsis Campaign Collaborative is about right now, is actually capturing patients that are on the wards. And what we have recommended is this, is that you institute a program where you are screening every patient, every shift, every day for severe sepsis. Every shift, we ask people to screen. And you can use any screening tool that you choose. They're very simple, but as the nurse comes on, we ask her to, when she's doing her initial assessment, screen for severe sepsis.
Okay, excellent. Okay. Thank you so much.
You betcha.
And our next question comes from Susan Nelson from North Memorial Medical. Go ahead.
My question has to do with when a patient presents with severe sepsis and you draw a lactate level, at what hour are you required to repeat that lactate level if it came back greater than 4?
Within 6 hours of presentation. So, yep, that's it. So you need to learn your presentation time, and once you've got a presentation time, you need to repeat the lactate within 6. And it's actually, the core measure is that it should be repeated, and the Surviving Sepsis Guidelines should be repeated if the lactate was elevated at all.
Okay.
Right.
Okay, thank you.
You betcha.
And our next question comes from Jamie Underwood from Unity Point Methodist. Jamie, go ahead. I have just a couple of questions. On the repeat lactate, we have had some questions from our ED physicians. What would be the earliest time to repeat? Would it be after the fluids?
Yeah.
Sometimes they sit in our ED for a while if we're waiting for a bed, and they might get missed once they get to the floor.
Yeah, I understand that. And yes, it's perfectly acceptable. If that first lactate is increased, after I've given my initial fluid bolus, I will go ahead and send another lactate myself, and that's how we practice. And your core measure only dictates that it has to be done within 6 hours of presentation if it was initially increased. So, yeah, that's perfectly A-okay. It is not too soon after your initial fluid boluses.
And then how have you gotten around that? I guess it's a fear that you're going to fluid overload these patients with the 30 mils.
Yes. So this is what I try and instruct people. You have a patient typically who's sitting there in the emergency room who maybe does have chronic heart failure. And by the way, we didn't have the time to go into pathophysiology today, but all patients with severe sepsis have reduced myocardial contractility and a lower ejection fraction than normal. We see people in septic shocks that we know had a normal ejection fraction 2 weeks ago who today have an ejection fraction of 10%. So severe sepsis itself causes cardiovascular dysfunction. So there are 2 or 3 things to keep in mind. Number one, when they present, most septic patients actually are a bit on the intravascular volume depleted side. Just statistically speaking, that's the case. Number two, even if they have chronic congestive heart failure, they still have a stalling mechanism that needs to work in order for them to perfuse their organs. Number three, what everyone is so worried about is they're going to cause pulmonary edema. And what I tell them is it's a long, long road from breathing room air to requiring intubation or mechanical ventilation. There's all kinds of room for giving supplemental oxygen in between, giving oxygen by face mask, maybe using a BiPAP if you have to. And of course, if you're in a smaller hospital, I understand you don't necessarily intubate with as much frequency as we do in a bigger hospital. If you're in a larger hospital, anybody listening here, it's what we do as intensivists is intubate people who need it. In point of fact, it is exceedingly rare to induce pulmonary edema that causes any major difficulties at all in a patient with severe sepsis who has either hypotension or a lactate greater than 4. Simply, it's an overstated fear that really does not present itself in real life very often at all.
Right, and I think what we are seeing where we get the most pushback are those patients who maybe have sepsis or one organ dysfunction that puts them in that severe sepsis category. They give them a little bit of fluid, maybe a liter, and then they go to the floor and they're on a maintenance that, fluids of about 100, and then it's 3-4 hours down the road, and then they go into septic shock.
Yep, exactly. I'm with you 100%.
And it's just so hard to get them to understand that really to give those fluids up front prevents that on the back end.
Indeed it is.
I don't know if you have any good answers to how
to do that. No, and in point of fact, so there's several things. All I can tell you is I know this, that all intensivists know that in a patient with severe sepsis, your first 2 liters of fluid are free. That's the way we say it. The first 2 are free. Just give them because the patient will need them. There isn't great data about this. I am currently embroiled in a research project to attempt to demonstrate that it does not hurt people to get 30 mLs per kilogram just because they have chronic congestive heart failure. But that data isn't out yet. I don't even know what the results are going to show yet. So
even both consult cardiology because they have a troponin leak, and the cardiologists are saying it's because of septic shock and ischemic demand, and they're saying to resuscitate, and we just can't get some of those docs to get over that fear.
I know. It's a major fear. It was ingrained. I don't know how that particular fear, of all fears, gets ingrained into people in medical school, and the fear of sepsis as a much bigger killer than congestive heart failure or pulmonary edema is not ingrained.
They come in as a trauma, which and how severe would you not do would resuscitate them. That's never a section.
I love that analogy. That's a great one. And I think you are exactly correct. And it just takes education. Yes. That's all I'll say.
Thank you. Bianca, how many more questions are in the queue?
We have 2 more.
Okay. Could we say, to be sensitive of Dr. Simpson's time and knowing what his desk looks like since he's been gone, can we take those last 2 questions? Any other questions after he answers these 2? I will put into the chat my email address. They can be emailed to me, and I can aggregate them and send them on to Dr. Simpson so we don't drown his inbox.
Good idea.
Or you can't, because I know that's probably full. So go ahead with the last 2 questions, please.
Okay, perfect. The next question comes from Pam Tabas with Newton Medical Center. Pam, your line is open.
Mm-hmm.
Okay, it's Karen again. Going back to what a previous person asked regarding time zero, how do you establish the best time zero, knowing that it's easy when sometimes they present to the ER in triage and they meet organ dysfunction criteria then. It becomes muddy when they're out on the floor and you get lab tech at this time, you get vital signs at this time, and now you're going off of several different times and no confirmed or hard time zero to go on.
Right.
And it's my understanding it has to be documented by a mid-level or a physician provider.
Now that's a new one on me for our core measure that it has to be documented by a mid-level or a physician. What I know is that what Medicare is operating on, and actually this applies to both emergency room and to the floor, they are operating on the time at which severe sepsis diagnosis can be made. And actually, so your chart extractor for your core measure is going to look at not when did a doctor say it was there, not when a nurse said it was there, but when the data actually corroborate. We have a white count, we have tachycardia, we have a lab that demonstrates organ dysfunction or a note that demonstrates organ dysfunction, and that's your time zero for the abstractor. Now, if you are going forward in time, as we all do, if we're trying to see our way through the fog, then it is the instant you get that last piece of information that confirms, that becomes time zero.
Okay.
And I personally, the way I like to drive SCCU is to say, okay, if let's say the patient presented with an infection and SIRS, and we send a lactate, and the lactate takes its own sweet time, and for whatever reason tonight comes back in an hour, but it's elevated, well, actually the time we sent it, the time that we saw those initial signs is time zero, but that's not necessarily how the core measure is going to be extracted. Is that clear?
Yes, that's clear. That was the fear that in retrospect, EMS will see severe sepsis could have been documented at 0800, whereas we didn't catch it until 1400. And
that is exactly correct. And that's what CMS is trying to do by making us report this, is to say, look, here's where all the data showed it. You guys need to take steps to get better at identifying it. That's exactly the point of the core measure.
All right, thank you.
Mm-hmm.
And our last question comes from Catherine Rucker from OLA Medical Center. Catherine, your line is open.
Hey, Dr. Simpson. When you're determining a source of infection, do you also include the inflammatory process, for example, pancreatitis? Would that be an acceptable source for the screening for the infection process?
Well, yes, because pancreatitis is very frequently associated with infection. However, pancreatitis per se, if you look in retrospect and you go, this was just pancreatitis and it was not an infected phlegmon or an infected pancreatitis, then it really doesn't count as sepsis. you're fortunate. I mean, if I've got pancreatitis, unless I'm absolutely 100%, like I know I've got biliary obstruction, or I know that I've got a chronic alcoholic and it's so high likelihood just pure pancreatitis. But oftentimes when you see pancreatitis, it doesn't hurt to get that dose of antibiotics up front, and then let the fog clear and decide, okay, well, this wasn't an infection after all, so let's stop our antibiotics.
Thank you.
Okay, you bet.
And we have any questions at this?
Great. Sorry, Bianca. Dr. Simpson, we had two what I think are very quick responses from you in the chat.
Okay.
The first one is atrial fib a common outcome in patients with no cardiac history?
No, not necessarily. In severe sepsis, not necessarily. But there are a lot of things going on in the myocardium during severe sepsis, and so it is a possible outcome. It's just not that. It's not a high incidence or high prevalence outcome.
Okay. And the second one is, we do not measure D-dimer here. Why do you include it in your workup?
Because the means, the final common pathway in the pathophysiology of severe sepsis appears to be disseminated intravascular coagulation. There are 4 labs that need to be sent to diagnose disseminated intravascular coagulation. They are platelet count, they are INR, they are PTT, and they are D-dimer. The more of those 4 things that are present and positive, the greater the likelihood that DIC is indeed present. For the purposes of sepsis, if any of those are out of bounds, we consider it sepsis-related DIC. Perhaps with the exception of that chronic liver disease patient who can't make fibrinogen in their liver and it's always low. But in any other patient we would consider those. We certainly say the criteria in the literature for diagnosing DIC are you would like to see 2 of those things out of bounds, and then you say DIC is present.
Okay, thank you. And then somebody did ask if doctors in rural areas have this outline to follow, and I know that in Kansas you have been providing things to the rural physicians.
I have indeed. So let me tell you, and as you know, the core measures don't, strictly speaking, apply to our 83 critical access hospitals. So let me give everyone an additional, I should have put this in the talk, an additional URL. It is www.mwcritcare.org. That is the homepage for the Midwest Critical Care Collaborative. On that homepage, you will find a section that says Shared ICU Quality Improvement Files. You can click, it's over on the left, upper left-hand side. Click on that, it will take you to a page that has all sorts of things that people have contributed for helping to take care of the sepsis patient, all the way from structured order sets to, we have a process to follow for smaller hospitals in the state of Kansas, where we give you different time goals because we think that you need to triage patients to get to a larger center. And so what we ask you to do is to achieve that triage and make that decision within 2 hours of presentation in a severe sepsis patient. But you'll see it, and it's a simpler thing that does not ask for central venous access, ask for fluid boluses, assumes that not every critical access hospital has a lactate measure yet, and allows a substitution of a bicarbonate level. I also want to say if you are truly interested in improving the quality, please go to this additional place, www.kansassepsisproject.org. This is a sepsis quality improvement tool that allows you to track your approach and your outcomes to the severe sepsis patient, and put out reports and show how you're doing over the course of time, and all you have to do is sign up to use that. and it's provided free of charge for hospitals and providers in the state of Kansas.
Thank you. Dr. Simpson, thank you for agreeing to present today. Clearly, from the large number of participants that were on the webinar at one point, we were as high as 365.
Wow.
And it took a length of time to get folks on because we didn't anticipate enough phone lines. So we apologize for that. The call was recorded and will be posted to the Great Plains QIN website, so they'll be able to access the Q&A as well as handouts in the recording of the webinar. So, thank you.
There is one last thing that I will say. Are we still being recorded?
Yes, we are.
Yeah, good. Okay, so to everyone hearing the recording, I have already put 20 to 25,000 miles on my car driving to towns all over the state to talk about sepsis with doctors and nurses. I am more than willing to continue to do that. It is it's my reason for living, if you want to know the truth. So please talk to me, use this email address. We will do what we can to get in-person training as soon as we can to your hospital.
Great, thank you. We have had a request already via the chat for a repeat performance, so we may go into installment number 2 at some point.
And that would be A-okay with me.
Great. Well, thank you for sharing yourself with us this afternoon, and rest up and get recovered.
Yes, ma'am. I appreciate it. Thank you, everybody, for being on. I really appreciate the opportunity to talk to you.
Thank you. Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect. Speakers, please stand by for your post-conference.